Disposition. It's the goal that we're all trying to achieve. Getting somebody to leave the hospital, okay? So when do you know if someone is good and ready for discharge? I'll tell you. It comes down to a couple big buckets. One, do they still need hospital level care? And or are they stable? Two, how are they getting their activities of daily living met? Are they able to meet these themselves? Or do they need nursing or medical resources to be nearby, like kind of in an assisted living? Or do they need like full-time nursing care? Like this person couldn't walk down the street if they needed to, and they would need either like a lift or like two people to like carry them to the bathroom. Okay? 3, is there a concrete plan for how they're going to continue to survive? So for the first point, do they still need hospital level care? It comes down to, do they need some kind of breathing or ventilatory support? Are they breathing okay? All right. Are they maintaining their vitals by themselves? Are all the treatments that they need either finished, or can they be finished just with pills? Or if they need some kind of IV treatment, can they get an IV via PIC or midline, or do they have a port? Can they do everything by the port? 2, how are they meeting their ADLs? Can they get up and walk? Can they prepare themselves meals? Are they cognitively intact enough to know how to feed themselves? Can they use their arms such that they can feed themselves? Can they toilet themselves, bathe themselves? How do you determine that? As somebody's getting closer to being discharged, sometimes if there's a question of whether or not that patient can walk or if they need assistance to walk, then you ask occupational therapy, physical therapy to see them. PT, OT, speech language, okay? You want to think about PT as everything below the belt. Can they ambulate? Can they transfer? Can they walk? And then you want to think about OT as everything kind of above the belt. Are they able to manipulate things that they need with their hands or with their mind in order to survive? All right. And then speech language is, swallowing, cognitive. So then you'd want to get those evaluations, and those evaluations would yield recommendations like, okay, this patient's safe to go home. If it turns out they need a whole lot of help or they need some nursing care, so it may be social work or case management's job to try and find like a SNF, a skilled nursing facility, where they can undergo like maybe some subacute rehab, or an acute rehab facility where they're going to be doing rehabilitation a little bit more than they would at a SNF. In my experience, there's a lot of anxiety surrounding leaving the hospital. I never would have imagined that there were so many people who wanted to make the hospital their permanent home. A large part of our job is addressing the anxiety that comes from leaving the hospital. Not only anxiety from the patients, but from their families as well. I think sometimes it's understandable, okay, if somebody who's pretty elderly lives alone and they're having falls, and maybe they don't have any family nearby to help, so they're worried about whether or not the patient is safe to go home. So they just kind of want the patient in the hospital. But my point is, for most people, the conversation about when they're going to leave the hospital should occur like the day of hospitalization. It doesn't always. In fact, I think most of the times it doesn't. If, in your opinion, the patient's going to be fit for discharge in like 2 days, tell the patient and the family, I believe you're going to be fit to discharge in 2 days. If today is Monday, say, I think Wednesday is going to be your day. You've got to have that conversation, because sometimes people are cool, but my former attending used to say all the time, expectations are the root of frustrations. So, setting expectations is so important. If you knew the patient was going to leave on Wednesday, but nobody else knew that, the patient didn't know that, and the family didn't know that, okay, and they thought they were going to be there until Friday, and then on Wednesday you go, surprise, surprise, you're ready to go today. In my patient population, like 75% of my patients would flip out If I said, oh, hey, it's 9 a.m., good to see you. Yeah, you'll be leaving the hospital at 2 p.m. this afternoon. A lot of my patients would flip out. So you got to have the discussion about when, as much as you reasonably can tell, when the patient's going to leave as early as possible, ideally at the time of admission. There's this thing that I noticed. Patients, I think, feel safer in the hospital, probably because they don't realize all the bad things that can happen from being hospitalized. Because it hasn't happened to them yet, maybe. And so they're like, I'm safe here. People are helping me. This is a great place. What if something goes wrong? But I think lay people don't understand how risky it is to be hospitalized. And they won't understand until something bad happens to them in the hospital. And you want to try and prevent that. You want to get them out of the hospital. Sometimes people are pretty reasonable, or at least their families are pretty reasonable, and they're like, yeah, we want to get them out as soon as it's safe. But not always. You'd be surprised how many people want to just kind of live in the hospital for the rest of their natural life. So it's really important to talk discharge early. Talk discharge early. If there's one thing I could mention, in fact, I'll repeat it again. Talk discharge early. Talk discharge what? Say it with me. Talk discharge early. Mark, do you mean I shouldn't talk discharge the hour before it happens? No, don't talk discharge the hour before it happens. Talk discharge what? Early.